So good morning all of you. We'll start with the topic of internuclear ophthalmoplegia. Internuclear ophthalmoplegia, a very important topic from both ophthalmology as well as medicine point of view. So before we begin with the discussion of internuclear ophthalmoplegia, a sincere request from my side would be to, before studying any topic of medicine, first we need to know the physiology of that topic, only then the pathology, followed by the clinical aspects and the management. So we'll follow the same trend as I've told you here. So before knowing about internuclear ophthalmoplegia, we need to know about the physiology of horizontal gaze. Physiology of horizontal gaze. So what does this mean? Physiology of horizontal gaze. Suppose this is the midline, this being the right side and this is the left side. These are the eyes we have. These are the beautiful eyes we have. Now suppose a patient is asked to look towards his right side. Okay, that means we have to look towards our right side. So what are the muscles that will be active here? Right sided lateral rectus and left sided medial rectus. So only if both of these muscles are contracting simultaneously, only then a patient can look, or only then a person can look towards his right side. Similarly, if the patient is asked to look towards his left side, left-sided lateral rectus must contract simultaneously, medial rectus from the right side must contract. Now, to bring about the contraction of the lateral rectus of the right side, this will be under the control of 6th cranial nerve, and medial rectus is under the control of 3rd cranial nerve. We all know this from our basic knowledge. Synergistic action of these two muscles, that is lateral rectus of one eye and the medial rectus of the other eye. So these two muscles are known as, this also we must be knowing these muscles, this pair of muscles from the opposite eye which must contract simultaneously to bring about a movement. These are known as the yoke muscles. Yoke muscles. Also, we started from the pathology, from the physiology of the eye, but I told you the question began with when the person is asked to look towards his right. So let us say if someone is asked to look towards his or her right. So this is the command that has been given to you. So command is interpreted by the frontal lobe of the brain. So what happens is, we all know that decussation occurs and therefore the opposite cerebral hemispheres control the opposite part of the body. So when you are asked to look towards your right, what happens is left-sided frontal eye field area gets activated first. Left-sided frontal eye field area is activated first. Now this brings about activation of the right-sided parapontine reticular formation. Before we go into the details of parapontine reticular formation, the fibers that carry the information from left side of the frontal eye field area to the right side of parapontine reticular fibers are nothing but the mesencephalic fibers. Okay, mesencephalic fibers carries information from the left side of frontal eye field area to the right side of parapontine reticular formation. Now this is basically the center or the control of it. This is the control of the horizontal gaze. Right side parapontine reticular formation will, what it will do is it brings about two major things. First, directly the right side of the parapontine reticular formation goes and stimulates the right-sided 6th cranial nerve nuclei. Clear? So right-sided parapontine reticular formation has stimulated the right side 6th cranial nerve nuclei. Stimulation means it brings about the contraction of the lateral rectus of the right side. We all know that lateral rectus is supplied by the 6th cranial nerve. Now you were asked to look towards your right. So what are the things we needed to look towards our right? Contraction of the lateral rectus of right side, but also we also need is contraction of the medial rectus of the left side. Half our job is already done, contraction of the right side lateral rectus. We also need the contraction of left side of the medial rectus. So what happens is, you can see that I have drawn another arrow here. What happens is, it brings this right-sided parapontine reticular formation, also stimulates another fiber group of dense gray matter fibers which are known as MLF, that is medial longitudinal fasciculus. Okay, medial longitudinal fasciculus. But this medial longitudinal fasciculus will be of the contralateral side. In this case, since this was the right side parapontine reticular formation, so this will become the left side medial longitudinal fasciculus. Now, this fibers which carries the information from the right side parapontine reticular formation to the left side medial longitudinal fasciculus are nothing but the internuclear pathway. As the name suggests, internuclear, that means two nuclei will be interconnected by this pathway. What are the two nuclei which we will be interconnecting is, one is your sixth cranial nerve nuclei and the other, let us see what the other is. Now, medial longitudinal fasciculus has the job of stimulating the same-sided medial rectus. Now, medial rectus of the same side, that means medial rectus of the left side. Now, medial rectus of the left side is carried by which cranial nerve? Third cranial nerve nuclei. So, third cranial nerve nuclei, sixth cranial nerve nuclei will be interconnected to each other by the internuclear pathway, also known as the medial longitudinal fasciculus. Clear? So, the physiology part is clear. So, we have the contraction of lateral rectus of the right side, medial rectus of the left side, medial rectus of the left side and lateral rectus of the right side to bring about the movement of the eyeball towards the right side. We can do the similar math when someone is asked to look towards his left. So the physiology part is clear. Now, having covered the physiology part, we will next go into the pathology, that is the disease per se. We told you that our topic was INO, that is internuclear ophthalmoplegia. Now it is very clear the internuclear pathway will be the pathway carries that the pathway in between the two nuclei, that is sixth cranial nerve nuclei and the third cranial nerve nuclei. You have already seen what was the pathway which was carrying the information between the sixth cranial nerve nuclei and the third cranial nerve nuclei. So that was the MLF we have seen just now. So basically the pathology will be the pathology in medial longitudinal fasciculus. Lesion in medial longitudinal fasciculus causes INO. Clear as the name suggests. Now, common sense we will apply to do the next maths. Let us see the first case of, let us say arbitrarily this is right medial longitudinal fasciculus pathology. So INO basically means any sided medial longitudinal fasciculus will go. We have arbitrarily taken as right. You may also take it as left. Pathology. Now we have already discussed that medial longitudinal fasciculus. What was the function of medial longitudinal fasciculus? Medial longitudinal fasciculus, we have already seen it contracts ipsilateral third cranial nerve nuclei stimulation. It causes the stimulation of ipsilateral third cranial nerve nuclei to bring about contraction of ipsilateral medial rectus. This is nothing new, we have already discussed. Now right side medial longitudinal pathology is there, medial longitudinal fasciculus pathology is there. So which muscle has already been paralyzed? That is right sided medial rectus. Clear? Right sided medial rectus causes adduction of the eye. So there is loss of adduction in right eye. Let us discuss it in diagrammatic form. Suppose these are the beautiful eyes we have. Pardon me for the bad diagram. This is the right side, this is the left side. Now the patient is asked to look towards his, let us say the patient is asked to look towards his right. Look to right. Now when you are asked to look towards your right, that means this side you are asked to look. So what are the muscles that will be active? Lateral rectus of the right side and medial rectus of the left side. This is functioning well, this is functioning well. Only pathology was the right side medial rectus. So we don't need right side medial rectus in this movement. So this movement will occur normally. Clear? Next is when you ask the same patient to look towards his or her left. What happens is, in this case, movement will be this side and this side. That means medial rectus of the right eye must contract and lateral rectus of the left eye must contract. We have already seen in our case that there was pathology of the right side medial rectus. So the right side medial rectus won't contract now. This action won't happen, but this action will happen because lateral rectus was not paralyzed yet. So what happens is there is loss of adduction of which eye? Loss of adduction of the right eye, and the pathology was also in the right side. So loss of adduction of ipsilateral in the ipsilateral eye. Also, what happens to this eye? This eye has already moved towards its left, but since medial rectus of the opposite eye has not contracted, so perfect movement has not occurred yet. Now what happens is this eye gets confused really, where to look towards your left side or to look towards your front, because it's already confused. It's not getting the synergistic action from the opposite eye. So what happens, in due course it will keep fluctuating here and there. This confusion will occur. This is basically nothing but nystagmus. And which eye is having this nystagmus? Which eye? Come on, this is your left side of the eye, and the pathology was in the right side of the medial longitudinal fasciculus. So we can say that there is nystagmus in the contralateral eye. So this is exactly what is INO. In a nutshell, we can write that INO is loss of adduction of ipsilateral eye plus nystagmus in contralateral eye. We can do the similar maths with left side pathology. Okay, exactly the same. You will just reverse all these things. Right side pathology, then you will compare it with the left side pathology. One more thing I want to ask you is, we have done this for internuclear ophthalmoplegia of only right side or only left side. Now what happens if there is a pathology in medial longitudinal fasciculus MLF of both the eyes, of right side plus MLF of the left side? In this case, what happens is nothing new, but we'll just discuss it once more. Medial longitudinal fasciculus was controlling the medial rectus of the same side. So right side will control right side, left side will control the left side. So medial rectus, again draw the eyes. These are the eyes we had, beautiful eyes we had, and this is the right side, this is the left side. Medial rectus is not functioning from the right side, medial rectus is not functioning from the left side. So what happens is, you know that medial rectus action is it is taken opposite by the lateral rectus. Now medial rectus is not functioning, so lateral rectus action is unopposed. This action remains unopposed. There is no one to oppose the lateral rectus action. Similar case occurs in both the eyes. That means lateral rectus of the right eye is functioning more, lateral rectus of the left eye is functioning more. Since it's not functioning more, it's basically unopposed action. So what happens is, the eye has got a tendency of abduction. Eye has got a tendency of abduction. Similarly here. So this eye looks towards this side, this eye looks towards the left side. So what popularly this is known as, instead of when you're asking the person to look straight forward to you, this person tends to look sidewards or laterally. So this is somewhat appears as if the person is looking towards the walls instead of looking towards you. So this is known as, popularly this disease is known as Webino. What is Webino? We can break it as wall-eyed. B is bilateral, INO is internuclear ophthalmoplegia. So this is Webino. What is Webino? Webino is nothing but medial longitudinal fasciculus of both the eyes are involved, and this is known as Webino. Clear? Now we will discuss about some interesting diseases with respect to this physiology and pathology. The first is 1.5 syndrome. We must all have heard about this syndrome in our neurology lectures as well as in our ophthalmology lectures. So what is 1.5 syndrome? Let us see. The basic pathology of 1.5 syndrome is that there is a lesion of both medial longitudinal fasciculus as well as there is a lesion of the parapontine reticular formation. How to understand this? Let us take the example that there is a lesion in the right side of medial longitudinal fasciculus as well as there is the lesion in the right side of the parapontine reticular formation. So this is basically same sided we are taking. Now we also have seen from our physiology part that medial longitudinal fasciculus was controlling ipsilateral medial rectus. So there is right sided medial rectus pathology. What was parapontine reticular formation controlling? Just a quick review if you have forgotten. Parapontine reticular formation was controlling the 6th cranial nerve of the same side as well as the medial longitudinal fasciculus of the opposite side, which in turn was controlling the medial rectus. So we can say that the parapontine reticular formation was carrying the ipsilateral rectus, lateral rectus as well as contralateral medial rectus. Clear? We may repeat this. Right-sided parapontine reticular formation controls the right-sided lateral rectus as well as via the medial longitudinal fasciculus it also controls the contralateral 3rd cranial nerve nuclei, that is contralateral medial rectus. So the pathology here is right-sided lateral rectus as well as the left-sided medial rectus has gone. So these are the muscles that won't function. So let us take up the case scenarios when this person is asked to look towards his left side. So everything is happening in the horizontal gaze. Remember, we have started all these things with horizontal gaze. Now this was your right side, this is the left side. Patient is asked to look towards his left. So when you are asked to look towards your left, what are the muscles you need? Medial rectus of the right side, lateral rectus of the left side. Now you tell me, medial rectus of the right side, is it functioning or is it gone? It's gone. Lateral rectus of the left side, is it functioning or is it gone? It's not gone yet. So this is functioning. So what happens is there is only half a loss. There is only half loss. Clear? So what happens is left eye can abduct, left eye abducts. Now the same patient is asked to look towards his right and look towards his right. Now what will happen? What are the muscles we need to look towards your right? Very easy. Lateral rectus of the right side, medial rectus of the left side. Now see at the pathology we have seen right side lateral rectus, left side medial rectus and right side medial rectus. Are these functions retained? Compare. No. All of these functions have gone. Left sided medial rectus has gone, right sided lateral rectus has gone. So there is complete loss. So let us say complete loss is 1 and previously we have seen half loss. That is half. So this is 1.5 syndrome. Very easy, no? This is 1.5 syndrome. One loss in one eye, one movement, and half loss in the other movement. This is 1.5 syndrome. So in a nutshell we can say what is 1.5 syndrome? When the patient is asked to look towards the side of lesion. See, there was a right-sided pathology. Patient is asked to look towards the right side. There is complete loss. No movement will occur. However, when the patient is asked to look towards the opposite side, that is right-sided lesion, and the patient is asked to look towards the left side, then there is only half a loss. The left side will abduct. So this is basically 1.5 syndrome. So loss of adduction of the same side of eye when asked to look towards the opposite side and complete loss when asked to look towards the same side is 1.5 syndrome. Since there is complete loss 1 and half loss is half, so 1.5 syndrome is same. Clear? Now 1.5 syndrome we have done. There is another fancy term called 8.5 syndrome. These things are actually not as rare as they seem. This is very common if you see a case of stroke in your medicine wards. So 8.5 syndrome is nothing but 1.5 syndrome associated with 7th cranial nerve palsy. 7th cranial nerve palsy. So there is no maths in this actually. 1.5 we have seen previously, and this 7. So 1.5 plus 7 is 8.5. That's how it makes 8.5 syndrome. Clear? What is 8.5 syndrome? 1.5 which we have studied previously. Along with that, there is a 7th cranial nerve palsy. Then this is known as 1.5 syndrome. Sorry, that is known as 8.5 syndrome. There is also another fancy term. You will be asked all these things when you go to your medicine posting. So what is another fancy term which we are talking about is 1/2 syndrome. 1/2 syndrome. So what is 1/2 syndrome? 1/2 syndrome is there is internuclear ophthalmoplegia in one eye plus ipsilateral 6th fascicular involvement with sparing of 6th cranial nerve nuclei. It's not actually difficult. There is internuclear ophthalmoplegia in one eye and the other eye 6th fascicular involvement. So 6th cranial nerve is actually spared and there is only fascicular involvement. So what happens is, so this will lead to half of horizontal gaze palsy, plus there is half of abduction deficit for 6th fascicular palsy. Easy. So this is 1/2 syndrome. We have done 1.5 syndrome, we have done 8.5 syndrome, and we have done 1/2 syndrome. So thank you.